principles that I'll repeat really on and on during the talk. Number one, estrogen in any dose can cause thrombosis. Number two, drugs that act like or oppose estrogen can cause thrombosis. Number three, hypercritical states can synergize with the estrogen effect. Next, and something I don't like to hear since I'm getting older, but age in and itself is a hypercritical state. And finally, the past predicts the future. So my goal as I give this talk is this: I'll try to emphasize one or more of these key principles as we move along, because I think that helps people understand, remember the issues around estrogen and thrombosis. Now, as I said earlier, age in itself is a thrombophilic risk factor, and it's a pretty interesting one that really for young women, the chance of dying from a venous thromboembolic event, mostly pulmonary embolism, is actually very, very low when you're young. It steeply goes up. So this is one key thing we need to keep in mind. I think a lot of the thing that goes on, the discussions about blood clots, birth control pills, is people tend to confuse relative and absolute risk. So that's another thing we'll highlight during this talk. So estrogen-containing contraception is probably the most common medication in young women. Last time I looked up, there's at least 12 million users. It was really first associated with DVTs right when it was first introduced in 1961. There was a paper about pulmonary embolism a few months later. And really, despite the reduction in estrogen dose, the risk remains. So overall, what is the risk? And again, it's age-dependent, but for the average user, it's increased about 2 to 3-fold. Now that sounds dramatic, but again, the risk of a young woman having a venous thromboembolic event is about 1 in 10,000. So on a birth control, 3 to 10,000. The risk tends to be higher with first and third generation pills. Remember, the first generation pills were basically estrogen bricks, so it was pretty, very, very high doses of estrogen. And third generations we'll talk about seems to be the progesterone component may have an element in this. This is a slide again showing that the relative risk compared to no users for first generation pills was substantially increased. We see now with the second generation pill, which is still our lowest risk, it's still about 2 to 3-fold depending what study you look at. Now, I won't go into totally in all the controversy about third generation pills, but most people agree that compared to second generation pills, there is an increased risk. And why is this? Well, it seems to be the progesterone component. These large words, which again being a Hoosier I cannot pronounce, are different types of progesterone. And they're useful in that they reduce the androgenic side effects. But interestingly, the progesterone component of the second generation pill seems to modulate the prothrombotic effect of estrogen. So these actually reduce it, and it may be why they're a little bit more prothrombotic. Again, it's not an incredible risk. The relative risk in many studies is 1.7 to 2.6, which translates into 1 to 2 extra DVTs per 10,000 users. And again, if somebody doesn't want use a second generation pill because they're having excessive acne or things like that, this may be a very reasonable trade-off. The current controversy is Disparone, which is a progesterone with also anti-mineralocorticoid effect and anti-androgen effect. The risk varies, as we know. This is currently the controversial issue. But but it does appear from many epidemiologic studies in Europe, it is a double risk of thrombosis, a second generation pill. And the FDA has recently looked at this issue and stated maybe 1.5% relative risk. Again, translating to absolute risk, it's still a very low absolute risk, perhaps 1 extra blood clot in 10,000 women. Now, what about progesterone only? I get asked about this a lot. Again, I got 3 emails on it yesterday. And so probably the pure progesterone-only pills do not have increased risk of thrombosis. This has been looked at in several studies and is an alternative for women with hypercritical states and thrombophilia. The injectables maybe have increased risk, anywhere from 2.2 to 3 times the risk. It's hard to know, is this a real risk, or is it because these tend to have been used in the past at patients at higher risk of thrombosis. But in my practice, I tend to avoid these. It's very clear that the IUDs do not increase the risk of thrombosis. So the progesterone system IUDs are very useful alternative for women with thrombosis concerns. And in fact, for women on anticoagulation, I have a large clinic with hemophilia and bleeding disorders. The decreased menstruation can also be quite an advantage for women on anticoagulation, which is one of the big problems I see in our anticoagulation clinic. So these are a very, very useful form of contraception. So what are the modifiers of risk that we see with birth control pills? Well, timing's a big one. And there's an increased risk in the first 3 months of use. And there's relative risk of almost 12 that have been reported in this time. And I think it's just simply the fact that women who are going to have a thrombosis with estrogen are going to have it right when they start. The risk does persist throughout the time of use, and it actually does not go back to baseline until about after 3 months. So we see this initial peak, a persistent elevation of risk, and then it goes back to about baseline 3 months after stopping the pill. The age of the patient's also higher, and this is because the additive effect of thrombophilia of aging on top of the use of the estrogen. So again, this is a study of increased risk of thrombosis with the pill as patients get older. We see here particularly in the 40s and 40s, there is an increased risk of thrombosis, even compared to age 18. And again, that's adding the risk of the pill, the thrombophilia of the pill, and the thrombophilia of aging. The other big interactions is with inherited hypercoagulable states. And again, the relative risk in these studies have looked pretty impressive, anywhere from a relative risk of 10 to 99 times. That seems to be very high. Again, there's a predilection for interactions with thrombophilias and third-generation pills, but it's important to remember that despite these spectacular relative risk numbers, the absolute risk is still pretty low, maybe 28 to 50 thrombosis per 10,000 young women. This is a study from a large cohort of patients in Leiden, and we can see here having being on birth control pills in the study raised the relative risk of thrombosis by 3. Having factor V Leiden raised the relative risk of thrombosis by about 7. But again, there was a synergistic effect of both, where it raised the risk, the relative risk, by almost 35-fold. Now, people often wonder, well, gee, should we screen women for hypercoagulable states before they start birth control pills? And I think the answer to this is pretty much a resounding no. The issue is that most women with factor V Leiden, other thrombophilias on birth control pill, will never have a thrombosis. And so studies have been done, and what you'll end up doing is denying effective contraception to over 60 women to prevent 1 DVT. Now again, there's a family history of thrombosis, personal history, it's a different matter, but there's really zero utility, and I would argue harm, in simply blindly screening people, and that's why it's uniformly not recommended. So what are the recommendations? Again, no general screening. If somebody has a thrombophilia but no thrombosis, should they start birth control pills? This is a controversial issue. There's a very strong particular need for estrogen-containing contraception for other reasons, especially in a younger patient, teenager, early 20s. I have a detailed conversation, but we'll do it. If there's a strong family history of thrombophilia, patient arbitrarily over the age of 30, I really don't use it and will strongly recommend other alternatives. But I often run into this issue from people kind of doing blind family screening for thrombophilias. If there's a history of thrombosis, let's say after a car accident, really estrogen-containing contraception is contraindicated. As we'll go over later, the risk of thrombosis is high. Progesterone, many pills are okay. Progesterone, IUDs are okay, but really not estrogen-containing pills. The exception is if the woman is still anticoagulated. It's really very unclear if somebody's on anticoagulation if the pill will add to the thrombotic risk, and it is very clear that unplanned pregnancy is a major issue to deal with somebody's anticoagulated. So here, most anticoagulation experts will give a pass. Rings and patches. Patches have the same to higher risk of thrombosis as pills do, because there's actually a higher area under the curve for estrogen exposure. Same risk applied. Rings haven't been well studied, but again, there is literature. It has the same risk. and I treat all these the same as the pill with my risk management. So, people like the bear picture. I think next year I'll just be invited back to show vacation photos. Hormone replacement therapy. The overall risk of combined therapy is about double the risk, so slightly below the pill. But here's where age comes into play. And so the absolute risk is a lot higher, about 1 in 500. Estrogen-only hormone replacement appears to be a lower risk, perhaps 1.33. Again, we see the marked synergy with hormone replacement therapy in hypercoagulable states. Relative risk anywhere from 6 to 17. And again, the absolute risk is higher. Again, the same study from Leiden, showing triple the risk with factor V Leiden, triple the risk with hormone replacement therapy, and a synergism here. Now, what about prior thrombosis? And this is interesting because this has actually been prospectively studied. And there's a study of 71 versus 60 women with a history of DVT randomized to hormone replacement therapy. And this trial was terminated early. For women randomized to hormone replacement therapy with a prior history of DVT, the rate of thrombosis, including 3 pulmonary embolism, 1 cerebral vascular thrombosis, was 8% per year. With placebo, only 1%. So I think this is the only study that's really done this, but again shows that a history of thrombosis is a contraindication to estrogen, at least estrogen hormone replacement therapy, and I think by extrapolation, other estrogen-containing products. Now, the interesting thing is the hormone replacement patch may not have this thrombophilic effect. There's been a lot of studies, both some basic science studies and some clinical studies strongly suggesting there's no activation of coagulation, there's a lower to maybe negative risk of thrombosis. It'd be nice if this was prospectively studied, but this may be an option. So what do I do? Again, history of DVT, no hormone replacement unless anticoagulated. Hypercoagulable state, no thrombosis. This is a risk discussion I have with patients, but in some patients, I have recommended the patch for really, intolerable symptoms. And again, on anticoagulation, free pass. So what about estrogen-related thrombosis and the risk of future thrombosis? So estrogen, pregnancy pills, is the most common risk factor for provoked DVT in a woman. And there's increasing risk on how we can use this data to risk stratify the risk of future DVT. So this is a study that was published in JAMA. It's a bit of a confusing slide, but there's really 2 groups of patients. One are women who had a DVT, were not taking oral contraception at the time of their first event, and then later either took the pill or did not take the pill. And as you can see here, using the pill doubled the risk of having a future DVT. So this is why I feel if you've had a DVT in the past, you should avoid estrogen-containing contraception in the future. And again, this is particularly risky if you were taking the pill, had a DVT, really re-exposure triples the risk of having a thrombosis compared to no re-exposure. The second interesting thing is that if you look at women with hormone-related thrombosis, their risk of a future DVT, if they're no longer exposed to hormones, is actually very low. In this study from the PREVENT trial, it was only 5% compared to 15% for non-hormone-related thrombosis. And in fact, a woman with a hormone-related thrombosis had a substantially lower risk of recurrence than men, and a substantially lower risk of recurrence than other women whose DVT happened for another reason. So when I decide on a coagulation decision, if somebody's had a DVT on hormones, and obviously they can be stopped, that's a provoked DVT, I just do 3 months on anticoagulation. That's a major provoking factor, and really even in the phase of thrombophilia can mean short-term anticoagulation. So women who have DVT due to estrogens have very low rates of recurrence. It's not influenced by most genetic hypercoagulable states, unless there's other compelling reasons. There's been multiple thrombosis, mandates only short-term anticoagulation. The other thing that I alluded to is drugs that interfere with estrogen also appear to be prothrombotic. The classic's tamoxifen. We know, even though it's an estrogen antagonist, it still interacts the same way, and we see the DVT rates increase threefold. Other medicines that also antagonize estrogen or act like estrogen, at least for the bones, also has the thrombosis rate. Aromatase inhibitors, other drugs we use in breast cancer, may do it a little bit. That's still debatable. But again, that's where I come up with the guidelines of basically anything that influences the estrogen system, pro or negative, is thrombophilic. Assisted reproduction is really increasing. I see a lot of consults for this. It amazes me, the technology and all that goes on with that. There's really two interesting things. One is that with assisted reproduction, there does appear to be an increased risk of thrombosis. Curiously, mainly upper extremity. This is associated with the ovarian hyperstimulation syndrome. We see an increased risk of thrombosis, perhaps due to lymph flow, increased edema seen there, and we're starting out into prophylaxis women who get that. And if the pregnancy is successful, we continue it through there. It's unclear. I get asked a lot, this patient's factor V Leiden, she's going to undergo assisted reproduction. If there's been a personal history of thrombosis or major family history, I actually have personally chosen to use prophylaxis in that situation. Again, a situation that needs to be better studied, but it seems to me high dose of estrogen, thrombophilia, not a good combination. So what if things are successful and with assisted reproduction or any type of, I guess the old-fashioned way of reproduction, pregnancy occurs? Pregnancy, there's a lot of factors that lead to a hypercoagulable state. There's a lot of estrogens. We start to see venous stasis due to anatomical changes. There's things that are therapies such as bed rest that add to this. So there's multiple issues. Risk of DVT, use of antithrombotics, and hypercoagulable states and adverse pregnancy outcomes. Again, we see modifiers. Age is a big one, and it's one we're seeing increasingly. The overall risk in pregnancy is about 1 in 1,000 of getting a DVT. Half before, half after delivery. And the risk rises with age. And this is becoming a major concern as women are having children at an older age. We see here an increased risk of thrombosis as women are getting older. Again, we're seeing in our clinics a lot of older women getting DVT after pregnancy. And again, it's a combination of age and thrombophilia. And we also see that the rate of fatal pregnancy complications due to DVTs also goes up. And again, especially at older ages, is actually higher than the risk of complications of birth control. The risk modifiers, again, we see if somebody's had a DVT in the past, the risk of recurrence is higher. This can be anywhere from 2 to 8%, especially if the previous DVT was idiopathic. We see that bed rest is also another modifier. And certainly if I have a patient with thrombophilia or other hypercoagulable state, I think about prophylaxis. All women who are on bed rest should at least be wearing antithrombotic stockings. Again, we see thrombophilia, hypercoagulable states with a powerful influence. Again, very high interactions here. And in fact, if you turn the question around, most women with DVT during pregnancy will be found to have a thrombophilia. It's a very powerful interaction. So what about therapy? Warfarin? No. All these wonderful new drugs we have? No. Heparin, low molecular weight heparin, maybe fondaparinux. We know warfarin is teratogenic, interferes with bone development. There's also a higher incidence of CNS defects and learning defects. The highest risk is 9 to 12 weeks and greater than 5 milligrams a day. So unless it's a very peculiar situation, like somebody with multiple heart valves, we'll use in the second trimester, really we avoid warfarin. Standard heparin I tend not to use. Number one, the PTT is very unreliable in pregnancy. You need to do heparin levels. Number two, it's an idiosyncratic reaction, but standard heparin over 6 weeks will lead to osteoporosis in 36% of women, and the dosing can be cumbersome 2 to 3 times a day at very high doses. Right now, low molecular weight heparin is the standard anticoagulation for pregnancy. It's safe, it's effective, and there's data of abundant use. We've used it in multiple randomized trials. It does not cross the placenta, it has predictable dosing, lesser rates of osteoporosis, and I think for long term will be our go-to drug. We use standard doses that are in your handout, but for prophylaxis, there's no need to check therapy. For therapy, I usually check the level about once a month to ensure I'm in the right range. Surprisingly, and again, probably because of lack of placental crossing, the levels, your dosing doesn't seem to need to increase that much over the pregnancy. Duration of therapy. If it's an idiopathic DVT, during pregnancy, 3 months or 6 weeks after delivery for the first thrombosis. Again, multiple thromboses buys you lifelong. There's a strong hypercoagulable state, like true antiphospholipid. We do it forever. Again, as I said earlier, weak, what I call weak, or the classic hypercoagulable state, protein C, protein S, and prothrombin gene mutation, does not seem to predict the risk of future thrombosis. So with those, even in the setting of thrombosis, I only anticoagulate short term. And always remember, breastfeeding is not a contraindication. I'm sorry, warfarin is not a contraindication of breastfeeding. So if somebody's going to be on long-term anticoagulation, it's okay to get back on warfarin after they deliver. History of DVT needs prophylaxis. Low liquid heparin throughout pregnancy, and then for 6 weeks afterwards. Probably a provoked DVT like car wreck, non-estrogen provoked DVT, we can do this postpartum. Thrombophilia and no DVT history is controversial, but most of us now, especially in younger women with no other risk factors, will only prophylax postpartum, not throughout the pregnancy. Again, if the patient's very obese, they're older, there's other risk factors, I often will elect to prophylax throughout the pregnancy. But in most uncomplicated situations, just after delivery. Now, it's controversial if all women who have a thrombosis during pregnancy need evaluation. I think it's important for several reasons. Establish duration of therapy, especially for the major hypercoagulable stage. We can intervene. There is somebody has antithrombin deficiency. Family studies, maybe, but it's a controversial issue. On the one hand, for the patients themselves, you may not do anything, but on the other hand, there's a high risk of finding them. So again, this is one of our controversial areas, but I think we'll have an informed discussion with the patient about screening, not screening. And as I said, I have in the handout, I do all the classic stuff. I don't do MTHFR. I could talk for another hour on how that doesn't mean anything, but I won't. We'll just say no. Usually I evaluate both things after pregnancy because pregnancy will influence many of the levels of hypercoagulable proteins, especially protein S. Patient on warfarin planning pregnancy, I do not automatically put on low molecular weight heparin. I just do frequent pregnancy checks because it may take a long time, and that'd be a long duration of low molecular weight heparin. Finally, are pregnancy complications thrombotic? There's a lot of thought that placental ischemia results in decreased fetal growth, fetal death, and pregnancy complications. And that's really because that the placenta becomes the blood supply to the fetus by 8 to 9 weeks. There's a strong association of thrombophilia and hypercoagulable states. Multiple studies have shown that with pregnancy loss, there's a strong association with thrombophilia. The difficulty with this, as I'll skip ahead slightly, is that this has not been replicated in clinical trials, that doing anything about this thrombophilia makes an effect. It's very clear if a woman has antiphospholipid antibody syndrome, there should be prophylaxis throughout the pregnancy. It's also very clear that unselected women with 2 or more losses, randomized trials say no prophylaxis. If somebody has definite thrombophilia, what do we do? The pendulum swinging for no prophylaxis. Multiple late losses, not last losses, but multiple late losses after second trimester, these are still uncertain areas and takes a detailed risk-benefit discussion with the patient. So I consider prophylaxis with 1 or more unexplained loss, especially if they're late and hypercoagulable state. Difficulty is women with no hypercoagulable state, and this is a very evolving field. It often really comes between a personal discussion between the hematologist, the obstetrician, and the patient. So the summary, as we said, is estrogens are thrombotic, but this risk can be modified by many things. Age, thrombophilia, history of thrombosis. And I think the other key thing is to remember absolute and relative risk. A DVT in a young woman especially teenager and 20s, is a very unusual event. Birth control, estrogen-containing contraception will raise the risk, but still, even with this, is a very unusual event. And I will thank you, and I'll be glad to field any questions or heckling.